Welcome, everyone. Welcome and thank you for joining us for yet another dynamic Newborn Toolkit webinar. Today's webinar is on babies and bugs. Next slide, please. Babies and bugs, innovations to address neonatal sepsis and AMR to mark World Sepsis Day. Welcome once again to the Implementation Learning Seminar Series. Welcome to the Newborn Toolkit community. This series aims to encourage collaborative learning for faster progress together for small and sick newborn care. Our 2024 webinar series is structured around the WHO UNICEF core components of small and sick newborn care. On the screen now, we have QR codes to join our newsletter in English, in French, and also to follow our channels on Twitter, X, LinkedIn, and Facebook. Next slide, please. Welcome once again to Babies and Bugs, Innovations to Address Neonatal Sepsis and AMR to mark World Sepsis Day, hosted by the Newborn Toolkit in collaboration with our ANA partners. We have many exciting upcoming events. On October 8th, we have a neonatal follow-up webinar where we'll discuss retinopathy of prematurity. On November 12th, we'll have our Toolkit birthday, where we'll be turning 3 years old and announce our essay winners and key updates. Please do introduce yourself in the chat and share where you're listening from today. Next slide, please. I'll now hand over to my colleague, Lauren.
Thank you. Alors, bonjour et bienvenue à tous nos participants parlant français. Aujourd'hui, le webinaire se concentre sur les bébés et microbes, les innovations pour lutter contre la septicémie néonatale et les résistants aux antimicrobiennes. Si tu veux écouter le webinaire en français, s'il vous plaît, cliquez sur le bouton de traduction affiché en bas de l'écran pour accéder à la canal français. On a aussi quelques événements à venir. Le 8 octobre, un webinaire sur le suivi néonatal de la rétinopathie de la prématurité. Et le 12 novembre, l'anniversaire de la boîte à outils où on annonce les gagnants de le concours d'essai et quelques mises à jour. Alors, s'il vous plaît, introduire dans le chat en indiquant votre nom et votre rôle. Next slide. So we're also very excited to have Dr. Naha Salim today as our host of the webinar. Dr. Naha Salim is a pediatrician, faculty and director of research publications and innovation at Muhimbili University of Health and Allied Sciences. She's also a clinical lead, co-principal investigator, and co-chair of the NEST 360 Alliance for the ongoing multi-country program. So without further ado, I will pass it over to Dr. Salim to continue with the webinar.
Thank you, everyone. Once again, welcome to this webinar. Next slide, please. Today, we are excited to welcome 4 main speakers on the babies and bugs. And for our first talk, we would like to welcome Dr. Oduag Okumu, who will take us through the talk, what bugs affect babies in the neonatal units in Africa. Dr. Okumu is an assistant professor of maternal and newborn health at the Medical Research Council unit in the Gambia with the London School of Hygiene and Tropical Medicine. She is a coordinator for maternal and newborn health research at the MRC unit in the Gambian branch. Welcome, Dr. Okumu.
Hello, thank you.
Remember, for any questions and comments, do post in the chat and we'll take a note of your comments and questions. Welcome.
Thank you, Naya, for the warm introduction. Hello, everyone. I'm just glad that you're here to join us today as we talk about bugs and babies. So I'll be going briefly through what bugs affect babies on neonatal units here in Africa. So please could you have the next slide, please? So before we get into the issue of bugs, it's important that we diagnose infection. So before you're able to get and identify what the pathogen causing an infection is, it's important that you collect the right sample and you're able to diagnose infection accurately. And so for anybody that's worked on a newborn unit, you can appreciate the frustration as is shown in this photograph on how to collect a blood sample from a baby, the right needle, the right cannula, whether you're going to attach a syringe or not. And then obviously, most importantly, if it's a blood culture, what kind of blood culture system you're using. We all know that for blood cultures in newborns, the yield is dependent on several things, including the volume. We should have at least 1 ml of blood, and the number of blood culture bottles that are being collected, and also the sites of blood collection. So the two main blood culture systems that are in use are manual and automated. Manual blood culture systems, which are still used in quite a number of facilities in the continent, have a high rate of contamination during subculture, and also one has to inspect daily for growth, unlike the automated systems, which as the name implies, they are able to indicate when there is the growth of an organism based on certain things such as production of CO2 and others. And so systematic review of neonatal infection etiology in sub-Saharan Africa that was published in 2019 show that of the 81 studies that reported blood culture techniques for diagnosing newborn sepsis between 2008 and 2018, 45% of the studies reported using manual cultures. And so if we have majority of institutions using manual blood cultures and we're not able to address some of the issues in sample collection, then of course we'd have contaminated samples which would affect the yield and the isolated pathogens. Next slide, please. And so the same systematic review looked at data that had been published across the continent, mostly for focusing on sub-Saharan Africa and not including studies in Northern Africa, really to look and see what was available in terms of data regarding the pathogens for invasive bacterial infections, sepsis, or bacteremia and meningitis. And so there were 151 studies identified over a period from 2000, but there were there were 82 studies between 2008 and 2018, and just over 52,000 neonates representing 26 countries on the continent. Most of the studies were from urban tertiary referral centers. Regarding a neonatal bacteremia or sepsis, the most commonly reported pathogens were Staph aureus, Klebsiella, and E. coli, while for neonatal meningitis, GBS was the most commonly reported organism, followed by strep pneumonia and Staph aureus. Next slide, please. So what was evident is that there were regional differences in the diversity of the pathogens. And for West Africa, Staph aureus was the predominant organism for sepsis, as well as meningitis. However, for Central Africa, we had Klebsiella topping the list for sepsis and GBS for meningitis. In Southern and Eastern Africa, GBS was still the most commonly reported cause of meningitis, whereas Klebsiella was most commonly reported for sepsis in Southern Africa and Staph aureus in East Africa. Next slide, please. And so from this study, there were lots of gaps that were noted. Of course, reporting gaps and insufficient information. And that was why we, Joy, Lorna, and colleagues developed the Strobe Neonatal Infections Checklist to guide authors on what information to present and to report when they're conducting their studies and reporting and writing up their manuscripts, so that we'll be able to compare data across sites and facilities. However, several gaps that were included were the fact that there were not any population level estimates of invasive neonatal infections. So the reports were mostly confined to tertiary institutions, and there were very few multi-site studies within countries or multinational studies between countries in the continent. Also, there was a lack of community level and rural data. So there were no community-based studies. And since the review has been published, there have not been that many community-based studies that have also been published. And we also have insufficient data on neonatal infection in home births, even though more than 50% of babies in sub-Saharan Africa are now born in facilities. We still have a significant number of babies that are born at home, and it would be good to know what the diversity of bacterial pathogens or any pathogens that cause sepsis among this group is. Another thing we found as a gap is the etiologic diversity and accurate identification. So most of the studies reported data on healthcare associated infections or single pathogens, but we do know that neonatal infection could be from several pathogens at the same time. And we also know that non-bacterial causes of infections are not often investigated, such as viruses or fungi. And then also conventional microbiology techniques may limit the accurate species level identification. So most of the facilities were struggling to do culture, and very few studies or papers report the use of other techniques such as PCR or whole genome sequencing, which is able to give a very higher level of species level identification. Then lastly, routine surveillance data is lacking. So we have lots of cross-sectional studies, but there are not many studies on national pathogen and AMR surveillance data. Next slide, please. Sorry, yeah. So one study that has tried to address one of the gaps is the baby germs study from South Africa. So this is a single country study, but it's a population-based study. And so they had data from all the provinces in South Africa. And what was interesting in this study was that they found that the cause of infection differed by syndrome. So whether it was meningitis or whether it was bloodstream infection or sepsis, the timing of the onset of infection, so whether it was an early onset infection or late, and also the facility and the province. So there within this country, there were differences in the diversity of the pathogens isolated. Overall, the most dominant pathogens were Klebsiella, Acinetobacter, and Staph aureus, which also mirrors what was seen in the systematic review. Next slide, please. Another study that has report has tried to look at the bacterial diversity of early onset sepsis in Africa. So this is a review that was done by Kirsty Sands and colleagues, and they looked at the current challenges with diagnosis of early onset sepsis and future opportunities. And they found out that within the continent, the most commonly reported pathogens responsible for early neonatal sepsis were Staph aureus and coagulase negative staph, Klebsiella, Acinetobacter. So you have the usual suspects here, and as well as E. coli and GBS. Next slide, please. So the Barnard study also attempted to look at the gap of just having single country, single site studies. So this is a multi-site, multinational study, which had 12 clinical sites across 7 countries. So within Africa, there were 4 countries, Ethiopia, Nigeria, Rwanda, and South Africa, but they had several facilities within these sites, within these countries. And so this particular paper, they were actually looking at gram-negative bacterial infections and antimicrobial resistance. And so they also had a list of pathogens, gram-negative pathogens that had been isolated among the cases of sepsis. And of course, the usual suspects are here, the Klebsiella species, Klebsiella pneumonia topping the list, and E. coli as well. We also have Burkholderia and Acinetobacter. The authors also report a high rates of isolation of Staph aureus, which wasn't the main pathogen target for the study, and they would give a more detailed description and report of the species in a later publication. Next slide, please. And so 2 studies have also tried to look at non-culture based techniques for accurate identification. The first is is from South Africa again. South Africa, I think they seem to be leading the race in identifying and reporting neonatal sepsis. And so this was a surveillance study, and they used quantitative real-time PCR with the TACMAN array card. And they were able to, this TACMAN array card has the provision for identification of 15 bacterial targets and 12 viral targets. And so with this, they were able to identify pathogens such as urea plasma as also being associated with neonatal sepsis and RSV. Then another study that was done using whole genome sequencing to investigate two outbreaks of Burkholderia capacia and Klebsiella in a neonatal unit. And the whole genome sequencing was able to give very high-level species differentiation and detection of AMR. And so what was initially thought to be just Klebsiella pneumonia was actually found to be two species of Klebsiella pneumonia, which was a smaller number of isolates, as well as Klebsiella quasi-pneumonia, simile pneumonia subspecies. And also the whole genome sequencing was able to show that the Burkholderia had actually been endemic in the units for as long as 8 years before the outbreak was identified. Next slide, please. So moving forward, what do we need to do? I think it's important that neonatal sepsis surveillance is integrated into our clinical care. And so this would enable us to be able to monitor trends in pathogens as well as AMR. So AMR is currently a global threat, and newborns are not spared from the scourge of AMR. And we're going to hear about that in later presentations. But having an active hospital and laboratory-based surveillance would help us to have an idea of the incidence of neonatal sepsis in our countries, in our facilities, in our provinces, and be able to characterize the etiology of the sepsis. And we'll also be able to explore pathogen-specific strategies to reduce the burden. So is the sepsis acquired horizontally in the newborn unit, or is it in the maternity unit, or is it acquired vertically from the mom? And then also we'd be able to integrate pathogen and AMR surveillance at the same time. So monitoring not just the pathogens, but resistance to the well-known antimicrobials that are used to treat infections. Next slide, please. And so that note, I'd like to thank you, and I'm happy to take some questions.
Thank you so much, Dr. Okumu. So we will move straight to the talk number 2. And we would like to welcome Dr. James Cross. Dr. James Cross is an assistant professor on infectious disease and epidemiology at the London School of Hygiene and Tropical Medicine, and also a member of Nursery 60 Alliance, aiming to improve neonatal care in Malawi, Kenya, Tanzania, Ethiopia, and Nigeria. As a microbiologist, he will be sharing with us on the ways of detecting hospital-acquired outbreaks across the 5 countries within the Nursery 60 platform, on the culture gap and scope for innovations. Welcome, Dr. James Cross.
Thank you. Hi, everyone. Today I'll be presenting on behalf of the wider Nursery 60 Alliance on detecting hospital-acquired outbreaks across 5 countries with Nursery 60, focusing on the culture gap and the scope for innovations. Next slide. So my presentation will begin to give an overview of Nursery 60 and the neonatal blood culture gap, and then we'll talk about the new avenue of work related to data-driven detection of hospital-acquired infections. Next slide. So firstly, just to give a short bit of information about the Nursery 60 Alliance, the Alliance aims to reduce deaths of inpatient newborns in support of SDG 3.2. It's a large multi-partner alliance bringing together national governments in 5 African countries with engineers, clinicians, and health systems experts. And in phase 1, we began working with Malawi, Kenya, Tanzania, and Nigeria. And now, as we move through 2024, Ethiopia has joined the alliance. And data is central to all that we do in Nursery 60. And one such data tool that has been helping us achieve sort of impact in Nursery 60 is the Nursery 60 neonatal inpatient dataset. Next slide. So the neonatal inpatient dataset has been co-designed, as I say, with country governments and collected routinely from each newborn admission. And key variables include if the newborn was inborn, outborn, length of admission, diagnosis, cause of death. Regarding measuring care coverage and quality, we collect information on vital signs and then interventions like CPAP, KMC, and infection treatment as well. Next clip, please. And then once aggregated together, this data goes on to formulate a sort of live real-time quality improvement dashboard called NESTIT, which is used locally by facility clinical teams to aid their quality improvement processes. And the NID allows for this kind of comparable data that can be used at all levels, from individual facility level all the way up through multi-country and program level, towards sort of the progress towards those key targets. Next slide, please. So using NID data across countries, we've been able to assess what we call is the neonatal infection detection gap. And this was a piece of work which looked at the admissions of about 150,000 newborns in 61 facilities, and to quantify that difference between antibiotic and culture use. And as you can see on the left-hand side here in figure 1, with countries on the x-axis, the key messages here is that there's very high antibiotic use with the purple bar. For admitted newborns at roughly sort of 70%, especially in contrast actually to confirmed diagnosis seen here in the turquoise bar. At the same time, you can also see that there's low blood culture use, so that light blue bar has a mean of around 8%, showing that blood culture gap is present here. And you can also see that there's non-existent antibiotic sensitivity testing in many of these facilities. However, when you look at figure 2, you can see that there is some large facility level variation with some outperforming facilities, indicating that culture is possible within these contexts. Next slide. So now when we're taking a sort of closer look at that facility level variation, and by comparing blood culture service availability across these hospitals, what you'll see here is a breakdown of performance tiers ranging from, say, the facilities that have, say, the worst performers in terms of blood culture up to the best at the top. Click, please. And it's important to note at this point that none of the facilities inside NEST 360 were lacking laboratory infrastructure, in the sense that they had a laboratory, it was working, and they had the materials available. Next. The main issue lies with these facilities, which is the majority in group 2 and 3, which have labs and are offering the service, especially in that group 3 seen there, but actually the use of that blood culture remains too low. Next. And on a positive note, there were 2 facilities which had reasonably high coverage rates, conducting over 50% on suspected cases. Next slide, please. Thankfully, this analysis was originally conducted a year or so ago, and now to sort of begin to sort of track cultures over time, you can see in this graph that there is some sign of clear progression, and it's starting to be made at some of these sites. However, although most of these are actually within smaller facilities, in particular in this purple labeled country here, they are seeing some improvement, but the larger facilities and in other countries in particular, there are significant issues. And so tackling these inconsistencies is a massive focus for us in phase 2 of NEST. Next. At this point, it's also important to note that there are potentially some medium to sort of low-hanging fruit, quick wins potentially for these facilities that are struggling. And here you can see a graph showing the raw number of admissions, blood cultures done, negative cultures recorded in the medical notes, positive culture recorded in the medical notes, and etiology of the bacteria in the medical notes. And this is just over time at one specific facility here, with the average of around 400 admissions a month. And then it's clear that there are a couple of several clear gaps. Next. You obviously have the detection gap, so the number of cultures being done is less than the admissions, and we're doing some qualitative work to understand this more, but the lack of blood culture bottles, clinical prioritization, workload, etc. are becoming through. Next. I think something that's really interesting is the lab result gap. And here you can see that quite a large gap between the amount that are actually done and collected, but actually the result getting back to the notes is a real issue there, and result communication and contamination might be causes of this. And then lastly, we have the etiology gap. Next. And this is key to understand the potential source maybe of the infection. And this is shown here as the gap between the amount of samples collected and obviously the etiology coming back. And this could be due to multiple reasons, but could be around lab capacity and also skills required to do that kind of workup. And these are all areas that we are particularly focused on in NEST. Next slide, please. So whilst blood culture rates are low, and as we've just heard from Uduak, most of the infectious cases in newborn unit can be caused by outbreaks. And then these predominantly affect premature low birth weight newborns. Usually it's the easiest way to sort of understand the presence of an outbreak would be to find the same bacteria and the resistance profile infecting multiple newborns in the unit at the same time. However, as we've just shown, it's quite difficult to do this when routine blood culture is not taking place. Next. So yes, we know that a culture of doing cultures is foundational, but what can we do today to help reduce mortality from these current outbreaks? Next slide. Well, in this new piece of work, we've started off by going back to those positive outliers and asking the question, click. What can we learn from these facility data to inform our approach on how we detect these outbreaks going forward? Next slide. Now, this is quite a messy graph and kind of deliberately so. But what I aim to show here is that there are several key clinical indicators related to infections tracked over time from one of those high-performing facilities. And on the y-axis, you've got the rate of all admissions, and on the x-axis, you've obviously got the time period. And among many of the lines which represent moving averages for things like antibiotic usage, mortality beyond 120 hours post-admission, mortality rate, the proportion of deaths linked to infection rates, you'll notice that there's a very dark, prominent black line, and this line represents the rate of blood culture positivity at this particular facility. And the key question we're now asking is what indicators are most strongly aligned with blood culture positivity rate, particularly during neonatal outbreaks within this unit. And through a series of analyses and evolving methods, we've identified that there are indicators that are most informative and correlated to the rate of positive blood cultures. Next slide. So now you can see our composite indicator in a time series plot, which is built from multiple clinical indicators and aligns with blood culture positivity. And it's applied to data here from one of those positive outlier facilities. And you can see the time on the x-axis over the course of NEST phase 1, and we're looking retrospectively at this case, and the composite indicator on the y-axis. And as the indicator moves above the facility-specific threshold, our methodology suggests that it is a week where a consistent spike in cases has occurred, seen by the red dot. And when you compare that, these suggested events with individual level medical notes, what we find is the following. So if you click 3 times, you find that now we're going through these series of events, looking at potential outbreak 1 on the left that has occurred between June, September 2021. We look in those notes, we see that there was an increased positive cultures, there was increased gram-negative pathogens above the normal threshold, and that during this period at that facility, admissions were around 500, there were around 300 suspected infection cases, and the infection deaths totals around 90, and 85 of these were all caused by Klebsiella species. 80 of these were caused by Klebsiella species. And I'm not going to have time to go through all the others, but then as you can see, you can start pulling out different outbreaks over time, and this is showing 4 years of data. Next slide, please. And this is just the final slide. So now with our analysis showing a potential link between that composite indicator and blood culture results, we're now hoping to use this understanding of the indicator relationships to infer trends in clinical data in sites without blood culture. And in this example, we've applied similar sort of stats methods to facilities Y and Z here, and identified previous potential neonatal outbreaks. And if you click, just highlighting some of those here. And we believe this is helpful. And as we now turn to sort of focus on this much more prospectively to detect outbreaks, we hope that we can really use this to reduce small one sick newborn mortality. And lastly, if you click it twice, thank you. I just wanted to focus on next steps. So something that we're really focusing on is continuing to improve our data quality, refine these methods, and use potentially more complex algorithms to help predict these events. And then as a community, I think as Uduak spoke to, we really need better methods. The gold standard of culture is, in most cases, at best 30% helpful. And so really we need to start working towards more molecular-based approaches in these facilities. And lastly, I think something that's really important is we need to foster that collaboration between clinicians and microbiologists and data scientists under sort of dedicated funding. Thanks very much for your time. Look forward to your questions.
Thank you, Dr. James Cross, for the updates. So just in a nutshell, we heard about what bugs affect our babies in the neonatal care units in Africa. and that highlighted the importance of having neonatal sepsis surveillance and learn and act on the trend we see. Dr. James Cross took us through the issues of prevention, detection, and control gaps, emphasizing on the importance of using our data. And clearly we see a detection gap at different levels, including the lab and the etiological gaps. And we need to have better data gold standard, but also above all extra effort and collaboration to build our efforts. So now we will welcome Professor Angela Gromowski. She's a pediatrician, pediatric infectious disease subspecialist and head of clinical unit, general pediatrics at Stellenbosch University, the Tygerberg Hospital branch, Cape Town, South Africa. And what I learned here, she's passionate about patient safety and data-driven improvements in the quality of hospital care for newborns and children. So Professor Angela, welcome. And she will take us through how we respond and prevent neonatal hospital-acquired outbreaks. And this is really important, linking our story and learnings for today. Welcome, Prof.
Thanks very much, Dr. Naya, and good afternoon, colleagues. Thanks. Could we have the next slide, please? And you can skip through to the next one after the disclosures. Thanks. So I'm starting with a case which will probably feel very familiar to all the neonatologists in the audience. And this was actually referred as all good outbreaks late on a Friday afternoon by our previous head of department. And he wrote to me, "Dear Angela, 2 babies, very low birth weight in the neonatal ICU have just died with a suspected infection. Both have cultured Serratia marcescens. What is this bug? I've never heard of it. Could it be an outbreak or what?" And so thanks to an alert NICU consultant, we were informed of the possibility of an outbreak. We then did our due diligence and went to the laboratory and sourced all of the previous Serratia marcescens that had been isolated from blood cultures and other samples from the neonatal wards in the last year. And lo and behold, we found a further 10 additional cases, which we plotted on a line list and compiled a Gantt chart to try and see how they were temporally related. We also pulled out all of their old folders and tried to find common denominators, one of which had been CPAP. They had all received non-invasive respiratory support at some stage during their neonatal stay. And so this was a clue that we needed to go and visit the respiratory technologists and the Central Sterile Services Department. What we found, you'll probably find in hospitals throughout Africa, but that is large-scale recycling of many resources, tubing, etc., that is used to support neonatal care. Not only were these CPAP circuits and ventilator circuits being recycled, but they were being processed through a machine that had been broken, condemned, and should no longer have been used. They then resorted to soaking the plastic tubing in disinfectant, which is a no-no in infection control world, and they hung it to dry, although it was not quite dry, and then sealed it in a plastic bag. We then proceeded to take swab samples of supposedly clean tubing, and 80% of these clean tubes grew gram-negative bacilli. This was several years ago, so we didn't have whole genome sequencing, but we used something called pulse field gel electrophoresis, and we were able to exactly match the strains from our baby's blood culture to some of the samples from our CPAP and ventilator tubing. And so we established that this was a clonal outbreak, a single species being disseminated across the unit. We had also identified the outbreak source, which was reuse and incorrect reprocessing of disposable tubing that was marked as single use. We took all of this information and evidence to the hospital managers, who were then able to introduce use of single-use circuits the very next day. And the washer disinfector was condemned and removed from use. And the Central Sterile Services Department staff were retrained around which equipment and disposable circuits could be reused and which could not. Next slide, please. So there are many factors that make neonates more vulnerable to developing infections and resulting in outbreaks. Many of these are related to the sick and small newborn population, and some of those factors are not modifiable, but others definitely are. So some of them are around the high rates of use of antibiotics, particularly in the absence of confirmed or strongly suspected infection, as James has pointed out, as well as environmental factors. These are incredibly important, and you may be surprised to know that all of these images come from my own hospital in South Africa, a middle-income country. So you can see dirty incubators, poorly maintained sinks and plumbing, hospital mattresses that are blood-stained, and equipment that is no longer functional and fit for use. And all of these challenges, together with lack of clean water supplies, lack of surveillance for infection, delayed recognition of outbreaks, result in many more infections that really should be preventable. Next, please. So what do we know from some of the published literature? So from point prevalence studies in several neonatal units conducted a few years back, at least 1 in 8 babies hospitalized on a neonatal unit has an infection at any point in time, although we suspect that these numbers may be much higher. And the most important infection to do surveillance on it is, of course, bloodstream infection. But as you heard from James, if you work in a unit where blood cultures are not accessible or have a very low yield, you may not be aware of infections and outbreaks happening under your nose. And so it may be necessary to do surveillance for other proxy markers of infections and outbreaks. So as we get greater access to molecular epidemiology and related genomic testing, we know that up to 90% of all infections may be healthcare associated. So not early onset, but healthcare associated. And that up to half of all of these infections are actually linked, so occurring in outbreaks. And this is just an example from our own unit in 2019, where we were able to show with whole genome sequencing that a single outbreak that started in December 2018 with a single serotype of Klebsiella that was carbapenem resistant could be shown to be linked for the next year to infections across all our neonatal and pediatric wards. In high-income countries, it's quite frequent to report outbreaks, up to 10 a year. But from low middle-income neonatal units, very few outbreaks are reported and even less are published. And so this extreme paucity of data and guidelines and outbreak surveillance is a problem. And as James highlighted, it's even more difficult to do surveillance if you don't have an established laboratory and a functional infection prevention and control service. Next, please. So we started very simply in 2017 with this as our motto. And what did we find? We started, fortunately, in South Africa, we have a fantastic service called the National Health Laboratory Service, and all blood cultures can be submitted with no cost to the patient to the laboratories around the country from all neonatal units. We have a fairly high detection rate and blood culture positivity rate between 10 to 15%. And so we started simply with our infection control nurse emailing out a line list of all the new positive culture from our newborn unit every Friday afternoon. And what became apparent to everybody, from the managers to the neonatal clinicians and nurses, was that outbreaks were frequent. And you can see, just scanning down that line list, that MRSA, there were 4 instances of infection within a couple of days in our neonatal platform. We then started plotting these clusters of infection and the overall infection rate in terms of bloodstream infections per 1,000 patient days on a run chart. And you can see just how many outbreaks we detected in the first 2 years of our surveillance. Next, please. And to summarize, these are some of the top factors from all of the outbreaks that we investigated that we felt were contributing or directly responsible for outbreaks. So number 1, a shortage of alcohol hand rub at the bedside. A shortage of staff to clean medical equipment, particularly incubators and the rest of the neonatal unit environment. We had problems with a very cluttered environment, which made cleaning difficult and increased contamination rates. We had a lot of damaged equipment, particularly mattresses, cabinets, and drawers that could not be closed. We had ongoing plumbing challenges in our very large, very old hospital, and patient care areas, cots and incubators very close to hand wash basins. And we postulated that gram negatives could be being disseminated through clouds of droplets from these contaminated sinks. And lastly, we were reusing a lot of equipment that was designated for single use, including saturation probes, circuits, and various tubing. Next, please. So this is probably the most difficult thing to do in one slide, but how you, in a nutshell, go about managing and trying to stop a neonatal unit outbreak is you have to have a good team, and fortunately or unfortunately, we've had lots of practice. And this team could include many different people, but traditionally neonatal nurses, doctors from the neonatal unit, the infection control nurse practitioner and doctor, if you have one, microbiologists, hospital managers, because addressing outbreaks costs money, pharmacists, infectious diseases, engineering, etc. To confirm the outbreak, you really need a case definition, and it can be as simple, for example, in a rotavirus outbreak, we use the definition any baby hospitalized on the neonatal unit who develops watery diarrhea. It's also useful to know your baseline infection rates, if that's possible, by collecting data over periods of time, as James has shown you is possible, even in neonatal units without access to laboratory bloodstream infection data. Then look for additional cases, because there will be many that you've not recognized, either because you haven't been able to take cultures or the size of your unit or for whatever reason. And then construct a timeline looking for what are the common exposures in terms of place, time, devices, procedures, etc. Then you really need to act. So all of this really happens simultaneously in real time. And you want to implement control measures based on the mode of transmission of that pathogen. So obviously for most of the neonatal infection outbreaks, it will be contact precautions. And there it's important to reinforce general infection control measures, notably hand hygiene, environmental cleaning, and also stopping reuse of certain devices and equipment and sharing on the neonatal unit. And lastly, and I cannot emphasize importantly, communicate what's going on. Talk to your staff on the neonatal unit. Inform parents, what can they do? They're often fearful and know what's going on. Speak to your hospital managers to open resources and funds to deal with the outbreak. Speak to the media so that it doesn't appear that you're hiding things, and document the effect of the interventions. Write up a full outbreak report and cost it, so that the next time you go and ask for an expensive piece of equipment or an additional IPC nurse, you have the ammunition you need. Next, please. So how do you approach neonatal outbreak detection? Well, clearly it depends where you work and what resources you have. I've described a setting where we have long established, widespread, good access to laboratory data. And so we use bloodstream infections, and we have a threshold that we've set based on our historical experience. But you could also look at individual pathogens, or you could just look at clusters like I showed you in that line list. And as James so elegantly described, there are many other ways to detect outbreaks and infections. You could just look at unit antibiotic utilization rate. You could look at what we think are deaths related to infection, so within 3 days of infection onset, or just all-cause neonatal mortality. But when you're collecting this really valuable data, please remember also to collect data on denominators. These are really important for making your data comparable and for accounting for admission fluctuations. So it can be anything, per 100 admissions, per 1,000 patient days, per 1,000 live births, whatever's easiest for you to collect. Next, please. And so I'm going to go quickly now, but really we used to think about outbreak and infection prevention just from the lens of infection prevention and control, which for most people can be summarized as hand hygiene and cleaning. But there's so much more around quality, essential newborn care that needs to be done to maintain skin integrity. That is a baby's first line of defense, and I could talk for an hour about that, but I won't. And then to promote colonization with normal flora, so skin-to-skin care and breast milk. And where possible in future, we hope there'll be a cost-effective probiotic, but also focusing on reducing unnecessary antibiotic use on your neonatal unit. Next, please. And if you like to think about it this way, I call it the circle of infection control, or the circle of protection for babies to prevent infections and outbreaks. You can pick all of the elements that are going to be part of your arsenal in preventing infection on your newborn unit. And you can see there are elements from all those 3 different mechanisms in which we can protect babies. Next, please. And so outbreaks really are frequent, but often unrecognized and underreported. They arise because we care for some of the sickest, most vulnerable patients in the hospital, but also due to multiple infection control challenges. We need to shift our thinking and the prevention paradigm, not only to do better with traditional IPC, but also to focus on essential newborn care. It's clear that local surveillance and analysis in real time is key, using whatever resources you have to your availability, which include alert clinicians who communicate when they see something unusual, and doing active surveillance as an early warning system for outbreaks. And where you've collected data, start to think about implementing outbreak thresholds, whether they are clinical or laboratory or both. Next, please. And so hopefully in the future, we'll move from the few published and recognized outbreaks to acknowledging the iceberg that we have yet to uncover. And that is the story of undetected hospital-acquired infections and outbreaks in African neonatal units. Thank you for your attention. Oh, and lastly, these are some helpful resources that Toby will post in the chat for you to manage your outbreaks. Good luck. Thanks.
Thank you. Thank you again, Professor Angela. I think we learned a lot here. Key messages, very well narrated. Outbreaks are very frequent, and it's not something which is hidden. Environmental factors contributes a lot, significantly. Devices used to save life needs to be safe for the babies, to save the lives of our baby. And many more tips in terms of approach on how to make our neonatal care units safe for our babies. So on that note, I would like to welcome another talk, the final talk from Dr. Christina Obiero, clinician scientist based on the Kenya Medical Research Institute, Wellcome Trust Research Program, Kilifi, Kenya, but also principal investigators on the NEOSEP1 trial, again also leading a SNP African clinical microbiology surveillance for neonatal sepsis and antimicrobial resistance. Welcome, Dr. Christina.
Thank you very much for that kind present. Welcome and good afternoon, colleagues. I'm happy to be here. So I'll be talking about antimicrobial resistance threats for neonatal outcomes and solutions, including antibiotic stewardship. Next slide. So we'll start off by looking at the burden of resistance in LMICs, and also look at the drivers of resistance within neonatal units, and look at strategies to combat antimicrobial resistance, including current and planned work. And finally, look at the challenges that we face in implementing strategies to combat antimicrobial resistance in our setting. Next slide, please. So neonates are disproportionately affected by resistance to antibiotics, particularly in LMICs, where disease burden is highest and laboratory capacity is limited. Antibiotic treatment in neonates is largely empirical, and current antibiotic treatment guidelines are based on limited evidence, which haven't been updated over the past decade. So high resistance rates to the currently used antibiotics have been reported and are associated with a twofold increase in the risk of having serious healthcare outcomes, such as low cure rates and prolonged hospitalization. And they're also associated with a threefold increase in mortality. So antibiotics remain to be indispensable tools in treating bacterial infections. And given the limited availability of effective therapeutic options in the pipeline, we need to preserve the efficacy of those antibiotics that are currently available to us. Next slide, please. So antimicrobial resistance is driven by multifaceted factors, including inherent traits of the microbes causing infection, and many other factors that involve both the prescribers and the consumers of antibiotics. So these different factors are shown here on the slide and categorized to different groups for easy understanding. And we know that neonates present with non-specific signs and symptoms when they come to us at the hospitals that you work at. And nearly all neonates are initiated on empiric antibiotics for suspected sepsis at admission, given the high risk of poor outcomes when treatment is either delayed or not given at all. So inappropriate antibiotic use and lack of cultures and antibiotic susceptibility testing contribute to the development and spread of resistance within the newborn unit. Other drivers of antibiotic resistance within the unit include overcrowding and poor sanitation. Next slide, please. Several interventions have been developed to contain antimicrobial resistance, and this can be adapted within neonatal units to improve treatment outcomes. So this includes surveillance and monitoring of bacteria causing infection, antimicrobial resistance patterns, and also monitoring antibiotic use within the unit, and interventions that aim to reduce the spread of infection through the implementation of various infection prevention and control measures, which have been described in the talks that you've had before the one I'm currently giving. So access to quality and affordable antibiotics needs to go hand in hand with antibiotic stewardship programs in order to rationalize antibiotic use. Next slide, please. So we'll now look at a few examples of interventions that have been designed to contain antimicrobial resistance. So a few studies have investigated the impact of different antimicrobial stewardship programs in young children, particularly among neonates in LMICs. This slide and the next slide will show a recently published systematic review of the impact of stewardship programs on antibiotic prescription rates and appropriateness. And also the studies looked at the impact of these different stewardship programs on clinical outcomes, microbiologic outcomes, and cost effectiveness of the interventions that were developed and implemented. So out of 34 studies that were included in this system, in this review, only 3 were conducted in Africa, and only 2 included neonatal populations only. So although the review found that the interventions that were implemented across the different sites were associated with improved antibiotic prescribing and also associated with decreased infection and colonization rates caused by multi-drug resistant organisms, in addition to improved survival without prolonged hospitalization. Conclusions that were made from this review regarding the most effective approach were limited by marked heterogeneity of the studies because they varied based on the interventions that were implemented, age categories, and different settings were also presented, ranging from the areas where the critically ill children were admitted to where most stable babies were admitted. Next slide, please. And the other challenge when it comes to looking at the different tools that have been designed and implemented for the purposes of containing antimicrobial resistance is that they vary based on what the disease condition or the infectious disease condition that the tool was tested on. And then also we have different tools that incorporated clinical science and also the use of point of care diagnostics, which would also vary in terms of performance across different settings. Next slide, please. So when it comes to surveillance of infections that occurred within the hospital setting and also surveillance of resistance to antibiotics in our settings, here we are seeing a recently published systematic review and meta-analysis of point prevalence surveys in the African continent, which found a 13% pooled prevalence of hospital-acquired infections. And this was about twice that reported in the most developed countries. And the prevalence was highest in intensive care units and neonatal wards. So only 40% of the infections that were acquired during hospitalization documented a positive microbiological culture result, and gram-negative bacteria were the leading pathogens causing infection in these studies. So this shows that very few studies were conducted in settings where those reliable and capacity for performing cultures and also testing the bacteria isolated against different antibiotics. Few point prevalence surveys were reported in the Central African region compared to the rest of the continent. And then they also show that there's a high degree of heterogeneity methods and reporting. Therefore, this affected the generalizability of the results to other similar settings. Of note is that only one neonatal study was included in this systematic review meta-analysis. So this does cause, as has the review shown on the previous two slides, the need to perform more research among this vulnerable age group. Next slide, please. So studies looking at the surveillance of antibiotic use in LMICs have shown a high prevalence of antimicrobial use up to 80% in Nigeria. And this has been reported despite low capacity to test for bacteria causing infection, which will be important in guiding stewardship programs. So the Global Point Prevalence Survey reported an overall prevalence of antimicrobial use of about 50% across 17 hospitals in Tanzania, Zambia, Uganda, and Ghana, shown on this slide. None of the WHO reserved category of antibiotics was prescribed across the sites. And then neonates, again, comprised only 11% of the close to 2,200 pediatric patients included in this point prevalence survey. And indications for antibiotic use in this survey, the second leading indication was that among neonates, and this was medical prophylaxis for newborn risk factors. And this is found in the site that was based in Tanzania. Next slide, please. So I'll briefly talk about the surveillance platforms that are existing at our sites in Kenya. The Kemri Wellcome Trust Research Program, where I work, has over the years established surveillance platforms supporting clinical care and research in Kenyan hospitals. The Kilifi surveillance platform on the left side of the slide includes hospital-based surveillance for bacteremia at the Kilifi County Hospital, where admission, clinical data, outcome, and microbiological culture results are documented on an electronic database since 1998. All admissions, including neonates, have a blood culture sample taken prior to initiation of antibiotics. In addition to this platform, we have the Clinical Information Network in Nairobi, which was set up through partnership with the Ministry of Health and the Kenya Pediatric Association. And this network supports hospitals in improved documentation of neonatal and pediatric data and embeds research in routine clinical work. So an example of surveillance work done, or of research work done related to AMR under this platform is the CIN Antimicrobial Resistance Project, which is a prospective surveillance for bacteremia and AMR in 12 hospitals that are linked to high-quality microbiology laboratories. 3 of our research sites under the Kemri Wellcome Trust program, so that's Kilifi, Mombasa, and Nairobi, will participate in a multi-site surveillance of neonatal sepsis and antimicrobial resistance under the SNP Africa project, which is funded by the EDTCP. Under this surveillance, we plan to collect clinical data, antibiotic use data, microbiological data, and also conduct a quarterly point prevalence survey where we collect stool and perianal swabs for metagenomics analysis to give us to generate data on several endpoints, including colonization pressure within the newborn unit. And from the data we collect during the surveillance, we aim to develop alert signals for outbreak detection during the period during which we'll conduct the surveillance. And
Christina,
at the same time,
interrupt. Can you summarize? We are running short of time, only 2 minutes, 1 minute left.
Yes, thank you. So at some of the sub-Saharan African sites where we'll conduct the surveillance, we will run an antibiotic trial in parallel to this surveillance that we'll conduct. So we will run the NeoSep clinical trial, whereby we aim to investigate different antibiotic regimens for neonatal sepsis, and the trial is funded by the Global Antibiotic Research and Partnership Development. So during the trial, we are going to use a novel recovery score comprising of a set of clinical signs and symptoms to inform antibiotic escalation in neonates who fail to respond to first-line antibiotics. Next slide, please. This is my final slide. So the slide shows some examples of challenges that are encountered while trying to implement interventions that aim at combating resistance to antibiotics in our setting. And we do acknowledge that effective prevention and control of antibiotic resistance requires an understanding of the factors and contexts that contribute to its emergence and spread. Despite challenges shown here, neonatal units in low and middle-income country settings can work on building and implementing cost-effective and simple interventions on existing structures while prioritizing needs and maximizing on teamwork and inclusion of all stakeholders. So I'd like to thank you for your attention. Over.
Thank you, Dr. Christina, all the panelists. Due to shortage of time, I think the question and answers have been responded to the website. Please watch out for the upcoming topic on the toolkit, and we welcome again the essay winners, congratulate the essay winners, and welcome the next winners for the next round. Please look out on the package for the next winning competition, and the competition will be closed by mid-October. So not too late, please write and submit. Thank you for joining with us. And the webinar film will be available tomorrow and shared through our social media as usual and our social channels. You can scan for more information through the QR code. Let's together save the babies' lives, make them safe. And I would like to echo the last message Professor Angela said, you cannot manage what you cannot measure. So let's try to measure and learn and act through our measurements. Thank you, everyone. And at this note, thank you for your participation, and we welcome you to the next toolkit discussion in October 8th. Thank you.